Okay, so folks, we are at start time, 9:30 a.m. Central Standard Time. I'm sure we'll have some people jumping on here, but we like to start on time so that we can give everybody their day back as promised. So we're going to get started, and then we'll just kind of carry on, and I'm sure some people will be joining us as we go along. So I'm Brenda Andreessen. I am a co-founder of the Bridge Club along with Catherine Haskins. And we are really excited today to bring this interesting session together, sponsored by our friends Dechra and Dechra, and featuring our illustrious host, Dr. Christopher Byers, who is the critical care veterinarian. Those of you who follow some of his information and blog will know his experience, and that this is going to be a really fun and engaging sessions. But two quick things about the Bridge Club, because I think there might be some people on here who are not familiar with us. Catherine and I started the Bridge Club as kind of a TED Talks meets LinkedIn meets good old-fashioned book club. We wanted people to be able to come together and talk to each other and have conversations about topics that are of interest to, to what you have to do every day in the practice of veterinary medicine. So we really appreciate you being here. This session is being recorded, and Dechra will be invited to share, as will Chris, with anybody that he wants. The Bridge Club shares with people who are our all access members. And you can find out more information about joining as an all access member on our website, www.thebridgeclub.com. So I'm not going to say much more about us right now, because we really want to get into the conversation. So I want to say thank you again to Dechra and Dechra for bringing this conversation to be. And I'm going to introduce now Dr. Christopher Byers, who will start with our traditional Bridge Club toast.
And please, if you can, turn on your cameras. We want to see your face.
Turn on your cameras, folks. We'd love to see your faces.
That's part of the reason for the toast.
Well, good morning, everybody. Thanks for having me this morning. This is my first Bridge Club meeting. So I'm excited. So everybody, raise those glasses. Here's to health, peace, and prosperity. May the flower of love never be nipped by the frost of disappointment, nor the shadow of grief fall among a member of this circle.
Oh, that's a great one.
That's very sweet. Cheers.
I love that. Very
That's kind of deep, I have to be honest.
That is.
Well, Catherine, this is the first time we've met, but I'm a sentimental sap, so that shouldn't surprise anybody that actually knows me.
I love it. That's fantastic.
I'm that guy.
We do love it, actually. This is going to be good. All right, so I think, Chris, in the interest of everybody's time, let's just dig right into the topics. Start us off with some of those key points that you feel are really important to talk about when we're talking about how we tackle testing for Cushing's disease.
Sounds great. So as my background, yes, I'm a critical care specialist, but I'm also an internal medicine specialist. So I love endocrinology. And one of my favorite diseases is Cushing's disease. And I realize that it can be a disease that is challenging for some to understand the tests, and it can be challenging to treat. And honestly, addressing both of those topics in 25 minutes, or at least addressing them meaningfully, is not a reality. So we decided to focus on the testing component, because that's where I get a lot of questions. So the first point to remember is that hyperadrenocorticism is truly a clinical diagnosis. So what do I mean by that? I mean, one needs to really have more than just an abnormal test result on a minimum database set of tests before pushing forward or recommending screening diagnostics to a family. Like the infamous alkaline phosphatase. I mean, does anybody even really care about an elevated ALP anymore? I mean, it's the bane of an internal medicine specialist's existence. But in all seriousness, you do really need to have more than just an abnormal test result on your minimum database to justify the cost, to justify the experience to your patient of running a screening test like the urine cortisol creatinine ratio or the low dose dexamethasone suppression test, or of course, the ACTH stimulation test. Now, you may have heard some internal medicine specialists say you have to have clinical signs or evidence of pathology. So in terms of clinical signs, we obviously have the 4 Ps: polyuria, polydipsia, polyphagia, and panting, or if you want to use the medical term for panting, it's still another P, it's polypnea. Sometimes we also have different clinical signs besides the 4 Ps. And of course, just to keep us all on our toes, sometimes patients with Cushing's disease never even manifest the 4 Ps. Sometimes all you see is hepatomegaly on your physical examination, or the hair coat changes like symmetrical dorsal hypotrichosis, alopecia, comedones, calcinosis cutis. Even sometimes the only red flag will be recurrent bacterial skin infections or recurrent bacterial urinary tract infections. To be honest, recurrent lower urinary tract infections are one of the most common reasons that internal medicine specialists see patients. It's one of the most common reasons that primary care colleagues refer patients to us. For that type of patient with recurrent bacterial pyoderma or those recurrent lower urinary tract infections, invariably hyperadrenocorticism absolutely should be on your list of differential diagnoses for those patients. I also previously said we need to have evidence of pathology. Sometimes you're not going to have clinical signs, but you need to check for evidence of pathology. And I'm not talking about histopathology, but rather abnormalities like proteinuria or hypertension. If you have evidence of pathology of hyperadrenocorticism, then you are justified in pursuing screening tests. Furthermore, if those screening tests are ultimately consistent with Cushing's disease, you're then also justified in prescribing a treatment like Veterol, which is the only FDA-approved drug for both ACTH-dependent and independent Cushing's disease, meaning we finally have a drug that's available to us that gets the most common pituitary-dependent form, but it's also licensed and approved to treat primary adrenocortical tumors. So that's a great weapon to have in our arsenal for treatment. So let's stop for a minute. What questions are popping up at this point? Like I said earlier, I really like to answer things in the heat of the discussion and not make you guys wait until the end. I don't like it when questions lose their power. So please ask away.
Okay.
trying to like let everyone know we were going to unmute them all, and then I didn't realize we had a little echo issue.
Yeah, there's a wonky echo coming out somewhere. So let's do this. So when you have a question, unmute yourself and just ask away or post it in the chat. Or if we could see your faces, you could raise your hand. But since we can't see your faces, we can raise your hand, but we can't see it. So, please pop a question into the chat or just unmute yourself and ask away. This is a great opportunity to have this conversation with Chris. I know someone's got a question.
And I'm going to rely on you, Brenda and Catherine, because my screen is
We gotcha.
fun. So if there are questions, I want to answer them in the heat of the moment. I don't like making people wait until the end. So.
Okay, got one. Okay. First question. Yay, brave soul. Is there any concern for those persistent UTIs to be severe enough to result in a false positive LDDST?
That's a great question, and we're going to address it in the next section when I talk about the second point. So I like how you're thinking, because just by asking that question, I know that your thought process is spot on.
Perfect. All right. Anybody? All right.
Okay.
Let's go on and see what comes up next.
Okay, so moving on to the second point for our discussion this morning. So let's say we do have a patient with a compatible history and clinical signs of Cushing's disease. Let's say PUPD and hepatomegaly. And we even have evidence of pathology like proteinuria. The patient has a UPC of 2.9. Remember that Cushing's patients can have UPCs, urine protein creatinine ratios upwards of 3 or 4. That is not unusual at all. Now you get to pursue screening diagnostic testing, or as we all know, at least recommend it, okay? The challenging part of that process, there's no perfect test for hyperadrenocorticism. In fact, as you probably know, there's 3 major tests for Cushing's disease. The urine cortisol creatinine ratio, or the UCCR, the low-dose dexamethasone suppression test, or LDDST, and everybody's favorite, the ACTH stimulation test, or the STIM, as we call it. So let's briefly discuss each of those. For the UCCR, the urine cortisol creatinine ratio, it's very important. Gold, underline, bold, italicize. It's very important to remember that this urine sample must be collected at home or in a non-stressful location. And I think we would all agree that, unfortunately, you and I are considered stressors. Nobody likes to come to the veterinary hospital. And the current ACVIM consensus statement says that urine sample should be collected at home and at least 72 hours after a veterinary visit. Now, there is still some controversy as to whether or not one single urine sample is enough, or if we should pool multiple urine samples for the UCCR. There was no consensus reached on that. So currently, I simply ask parents to collect one urine sample. But again, the importance is that sample must be collected from home and at least 72 hours after a veterinary visit. The UCCR has poor specificity and high sensitivity. So, okay, practically, what does that mean? It means A positive result is not diagnostic for Cushing's disease because patients with non-adrenal illness have similar UCCR results. However, a normal or a negative result means the likelihood of hyperadrenocorticism is exceedingly low. And for all intents and purposes, one can just move on to the next differential consideration. I personally run the urine cortisol creatinine ratio to rule out Cushing's disease. It's basically the type of patient for whom Cushing's is technically on the list of differential diagnoses, but my index of suspicion is exceedingly low. So I'm just looking for a quick, non-invasive, easy way to cross that differential off my list. Then we have the low-dose dexamethasone suppression test, the LDDST, has high sensitivity, poor specificity, just like the urine cortisol creatinine ratio. Again, remember, all that means is that patients with non-adrenal illness can have test results that are falsely consistent with Cushing's disease. But when it's performed properly, when it's performed at the right time, this test is powerful. It's actually my preferred screening test because it has excellent specificity. Depending on what study you look at, 85 to 100%. Clients, however, are not always a fan of this test. Why? Because it takes 8 hours to run. And we all know that Fluffy can't possibly be away from her family for such a long period of time. So to go back to the original question, if that patient has a persistent bacterial urinary tract infection that is severe enough to be causing clinical signs, then yes, we would consider this a source of a potential false positive result, because it would be considered a non-adrenal illness. The challenge would be to successfully treat, manage the bacterial urinary tract infection, get that patient to a place where they're feeling comfortable with no clinical signs. And then if you're still concerned about Cushing's disease in that patient, pursue screening tests. Lastly, for the screening tests, we have the STIM. It has similar sensitivity to the low-dose dexamethasone suppression test, but it's more sensitive. For that reason, and that reason alone, you may hear internal medicine specialists recommend this test, the STIM, if a patient has other controlled, concurrent medical conditions. For me, the things that I want you to remember about the STIM have nothing to do with sensitivity or specificity. It has to do with how to perform the test in such a way that you can actually trust the results. Patients need to be fasted for at least 8 hours before running the STIM. Patients don't need to be fasted for a urine cortisol creatinine ratio for the most part. There are some idiosyncrasies, but that's well beyond what we're looking at in our discussion here. Patients absolutely don't need to be fasted for the low-dose dexamethasone suppression test, but they absolutely have to be fasted for at least 8 hours for the ACTH stimulation test. There is a form of hyperadrenocorticism called nutritional or food-induced Cushing's disease, where in the periprandial period, they walk, talk like Cushingoid patients. But when they've been fasted, they have no clinical signs whatsoever. After you inject them with their cosentropin, you need to put these patients in a kennel and leave them alone. Don't look at them. Don't talk to them. Don't give them water. Don't give them food. Don't make their butts wiggle. Don't make them bark. I promise you, they'll be fine in a kennel for 60 minutes while you run the test. If you interact with them, why am I emphasizing this so much? If you interact with them, you will falsely elevate their cortisol level, making your results inaccurate. Now, of course, we all know that every once in a while, we're going to run across that dog that just can't calm down in the hospital. Those are the kiddos that I actually have stay in a quiet room with the lights down and with the owner still present for that hour that it takes to run the test. Okay, so those are your 3 major screening tests for hyperadrenocorticism, meaning you've elected to run one of these because you have a patient with a compatible history and clinical signs or evidence of pathology. So let's take another brief break for questions. I know these tests can be tricky for a lot of folks, and that is absolutely fine. Let's make sure we get your questions answered. Don't be shy.
And just go ahead and unmute yourself. If you have a question, you can speak on in, or you can go ahead and put it into the chat.
So I have a question, Chris, to pose to you, and this is regarding communications with the pet parent. So all of these testing options are complicated, difficult, time-consuming. What are the 2 or 3 key things that you can recommend they share when trying to convince them to say yes to what you need to do in order to find out if, in fact, the pet has Cushing's?
Thank you for that question. That is a really important one, because essentially what you're telling these owners at the onset is, thank you for coming in. You recognize some things, and I think you were spot on in helping me identify a problem. Here's what I think's going on. It's a hormone disorder. And the good thing is that hormone disorder is generally pretty easy to treat. And with treatment, your pet could live a very happy, healthy, normal length of life. But diagnosing it is very challenging because there's not a perfect test. In fact, we may have to run up to 3 tests to make a definitive diagnosis. And I just want to be upfront with you about that process. I want to be as transparent as possible from the get-go so you trust me. You don't feel like I'm running needless tests. I think the more they hear that from you and members of your team, for example, I very much advocate for two adjunct things. One is using your credentialed veterinary technicians. These are medical professionals. They know what they're doing. They should be leveraged to the hilt. They want to be leveraged to the hilt for their medical credentials. So use them as part of your educational process with these parents. Two, you've got to recognize that some people are auditory learners and some people are visual learners, and then of course you have tactile learners. So what does that mean for us practically as veterinarians? It means that we'll have some people in our consultation room that latch on, grasp everything that we tell them in that consultation room. But you're also going to have some people that just nod, and when you ask them, does that make sense? They're going to say, yeah. And what they really mean is no. Okay? So give them a handout. Give them something that they can take home and read that can reinforce all of the main points that you made in that consultation room. That's what I would say that we need to do in terms of communication.
That's some really good points. So I see that we have someone who is unmuted. Do you have a question? And then we have a question in the chat also. So if someone wants to speak up, otherwise I'll read out the chat question. All right, well, I'm going to jump in. So Cherie has a question. What protocols do you use for LDDS and ACTH tests, please?
Okay, that's a great question, Cherie. So for the low-dose dexamethasone suppression test, you pull your baseline sample, and then you give 0.01 milligrams per kilogram IV of dexamethasone or dexamethasone sodium phosphate. It doesn't matter which one you use. What does matter is that you do your calculations properly. Remember that dexamethasone sodium phosphate is 3 mg per milliliter of dexamethasone and 1 milligram per milliliter of sodium phosphate. So just do your math properly, and you can use either dexamethasone or dexamethasone sodium phosphate. Then you collect a sample 4 hours after dexamethasone injection and another sample 8 hours after dexamethasone injection. For the ACTH stimulation test, you draw your baseline sample and then you inject intravenously cosentropin at 5 micrograms per kilogram. And then you collect your post sample 1 hour, 60 minutes later. Okay.
I don't see any other questions unless somebody has one that they want to speak up. We can move on to point number 3. All good?
Okay.
All
So
right,
the last point I want to make is simply to emphasize that one shouldn't perform any screening tests for Cushing's disease in patients with clinical illness, meaning anorexia, vomiting, diarrhea, coughing, uncontrolled bacterial urinary tract infections. Most of those that I just mentioned, they're not signs of hyperadrenocorticism. That doesn't mean that the patient with these signs of illness couldn't have Cushing's disease. It just means that those signs aren't due to hyperadrenocorticism, and you have to figure out what's causing them. You have to treat that condition, and once the patient has been relatively normal for, let's say, at least 2 weeks is generally the time frame that I use, then, honestly, and only then, should you consider testing for hyperadrenocorticism. If you look back over everything after you've treated that other condition, and you still have red flags going up for hyperadrenocorticism, then screening may indeed be very appropriate. But remember, one only pursues screening tests if the patient has a compatible history, clinical signs, or evidence of pathology. So that's our time together this morning. Thank you for joining me for this discussion. Of course, many thanks to Dechra for sponsoring this event and to the Bridge Club for hosting it, Brenda and Catherine. I've had a great time. Now, if anybody has been holding out with their questions, they've been too shy thus far, please fire away. I'll answer anything that I can.
Perfect. So the way we do things here at the Bridge Club is at the end of our promised time, anybody who must depart is certainly invited to do so, but we always do what was called an after party. And that's where our host graciously, almost always, agrees to stay a few minutes longer and answer any remaining questions. So we do, Chris does have a little extra time. So if you've got some questions that you didn't ask before or a comment that you'd like to share with the group, now would be a really phenomenal time to do that. So we'll take a few more questions and then, sign off in about 5 or 10 minutes, depending upon how long the conversation goes. So now's the time to speak up and to take advantage of having Chris right here to answer your questions.
Absolutely.
Because he's not an easy man to reach, let me tell you.
He's a busy man.
Once you get connected, it's fabulous. It's just a little hard at first. No, just kidding. He's very busy. So we are really thrilled. Chris, thank you for taking the time to do this with us too. It was really good information and really, from my perspective, really easy to follow. And you put really clear guidelines in place that I think people will benefit from.
Thanks.
Yeah. Yeah. So anything from anybody?
Very thorough, apparently.
Yeah. Well, Chris, you did a really good job, I think, of spelling everything out so that there weren't a whole lot of questions to be answered. Thank you for answering the question too about the communication, because clearly communicating the why behind the what is a really important part of getting to that yes.
One little trick that I learned a couple of years ago, I used to be that person that always asked people, does that make sense? That seems like a very benign, innocuous question in an exam room. And then I went to a communication seminar that had nothing to do with veterinary medicine. And they said, that's one of the worst things that you could ask. And I'm like, what are you talking about? That's one of the worst things you can ask. I've been doing this my entire career. And they said, think about it. You have somebody non-medical, for the most part, sitting in your room, and you're asking them to tell you if they understood everything you just said after you explained something that's pretty technically challenging. Do you really think they're going to admit that they don't know what you just said? Of course not. They're human. They're going to say, oh yeah, I got it, and walk out of there saying, I didn't understand a damn thing you said. And so instead of saying, does that make sense? I now say, did I explain that well enough? Did I explain that okay? Yeah. The theory behind it is pretty funny, because how it was explained to me was, there's no client on the planet that is going to abstain from telling you if you suck. There is no client on the face of the earth that is not going to tell you if you didn't do a good job. And so it's just a better way of asking a question to keep communication open. So instead of, does that make sense? I challenge everybody to alter their spiels to include, did I explain that okay?
I love the fact that we have not only clinical information here, but a little bit of communication tidbits right in the mix too. So,
which is great, because we do have another question.
We have one more question that popped up. So go.
I can see it. So I said that I think the LDDST was the best. Can I expand? The reason that I like it the best is because of the three major tests that we talked about. It has the highest sensitivity. So it's going to identify my patients when I run it properly, meaning I'm not running it on a patient that has an uncontrolled concurrent medical condition, that things aren't out of whack in some other aspect of that patient's healthcare. But when I run it properly, when I run it at the right time, because it has the best sensitivity of all three of those, then I choose the LDDST. That's why. And you could probably line 10 internal medicine specialists up and get 10 different answers to this question. That's just my take on it over the past almost 20 years.
Good job. All right. One more. When do you push an owner to do ultrasounds as well?
Okay, that's a great question. So we talk about doing ultrasounds once I've made the diagnosis. So what we just spent this morning talking about were screening diagnostics, because they're the most confusing, they're the most challenging of all the tests that we run. I perform an abdominal ultrasound once I've made the diagnosis, and now I'm trying to differentiate pituitary dependency from primary adrenocortical tumor. So some people run a high dose dexamethasone suppression test. So instead of 0.01 milligrams per kilogram of dexamethasone, it's 0.1. I honestly haven't run a high dose dexamethasone suppression test since my residencies, and I'm not telling you how long ago that was. I prefer an ultrasound, and depending on that ultrasound findings, is it obvious that both adrenal glands are enlarged or at the high end of the normal reference range for a dog of that size? Or do I see one big old primary adrenomegaly that would be consistent with an adrenocortical tumor? If it's not obvious on ultrasound, then I will run an endogenous ACTH level at whatever reference lab you choose. They all run it with a endogenous ACTH level, which is pretty cheap and easy. Your level is expected to be normal to elevated in patients with pituitary dependent or ACTH dependent Cushing's disease. The endogenous ACTH level should essentially be exceedingly low or immeasurably low in patients with primary adrenocortical tumors because of the negative feedback loop from that one adrenocortical tumor autonomously secreting cortisol, having that negative feedback loop up to the hypothalamus and the anterior pituitary.
Good explanation.
Very good.
Anybody else? We are coming up upon just about 40 minutes of time, and we usually try to keep it somewhere around the 40-minute mark, even with extra questions. So now's your last chance to ask a question. Otherwise, we're going to say adios and get on with the day. Okay, so once again, I want to say thank you very much to Dechra and Betterol for sponsoring this really great conversation. Thank you, Dr. Christopher Byers, for being our host today and providing such terrific information. And thanks to all of you for joining us today. We really appreciate you taking your time, and hope we'll see you again on the Bridge Club. So cheers.
Everybody.
Cheers.
There we go. Cheers. Chris, you have to drink. You can't not cheers and not drink. You have to drink.
I'm not going to lie, I finished it. So I don't want to do a fake sip.